Finding TB is central to ending TB. Finding TB is central to reducing the transmission of TB, because when you find TB, you enter people into the diagnostic pathway, you get them into the therapeutic pathway, or in the TB prevention pathway. So if you can exclude TB reliably, you can offer TB preventive therapy. But if you identify TB, you then put patients into a therapeutic pathway towards cure or treatment completion. The goal of this obviously is to save lives of the individual affected by TB, but more importantly, the public health goal is to reduce onward transmission of TB from somebody with the infection to those around them, close household contacts, close members in the community, and close members with which they interact with, because person-to-person transmission through the air is how TB is transmitted. The last decade has seen enormous strides in improved diagnosis of TB. In the past, we've had to wait 3 to 7 days in which to get a smear result, because smear microscopy has been with us for as long as the microscope has been with us. So we first identified TB. We know that Robert Koch identified it in 1882, and more than 140 years ago, right? So it's a long time. We were using the microscope to find TB. But since 2010, the world has moved towards a molecular-based test. In fact, almost every country in the world has adopted molecular-based diagnostics for TB, but it's really about scaling it up and making it accessible to every single person that desires a TB test. Patients may present with symptoms, and if ignored, the TB will spread within the lung itself, forming cavitatory disease. That means they form holes in the lung that communicate with the outside through the airways, enhancing the risk of transmission. The longer the time a person spends not being diagnosed, then the delay there is in getting appropriate treatment, the greater the chance of transmission, the greater the chance of extensive disease in the lung, and the greater the possibility of that TB organism spreading via the bloodstream to other parts of the body, what we call disseminated TB, and presenting with TB abdomen, TB brain, TB meningitis, and so on. And it's a more severe form of treatment with a very high mortality risk and requires far longer, more sophisticated diagnostics, far longer treatment. So there's the risk to the individual, there's the risk to the public. Early diagnosis is important to help mitigate all of those challenges.
So welcome, friends, to this episode of NTB Dialogues, 90 for 90 series, the Global Voices series. And we have amongst us two very special guests, actually. One, of course, is an old friend, a very widely, globally respected TB scientist, and a person who has really done amazing work in a country which has a very high burden of tuberculosis, but also a TB and HIV, and so many risk factors, despite so many challenges. Dr. Kogie Naidoo, she is a very well-known person. Probably all of us will already be aware that she is the deputy director and the head of the treatment research program at Center of the AIDS Program of Research in South Africa, CAPRISA. So welcome, Kogie. Real honor to have you amongst us.
Thank you, Bobby, and it's really a pleasure to be with you this morning. Thank you.
Thank you. Thank you so much, Kogie. We have amongst us Ashok Ramsarup. That is, he has been a luminary, huge personal inspiration for so many journalists and media people, not only in South Africa or African continent, but also Asia. One of the testimonies is he was awarded a special prize by a US-based organization for his contribution to advance using media, using SABC, Lotus FM, Newsbreak, to advance peace between India, Pakistan, and other countries in South Asia many years back. So welcome, Ashok Bhai. Ashok Ramsarup is a senior journalist. Ashok Bhai, thank you. We are very grateful. We knew that you underwent an important health procedure last week, but despite that, you are here. This speaks volumes about your commitment. Welcome, Ashok.
TB has been a major public health challenge since the late 1800s. South Africa is one of the 30 high TB burden countries, that account for 87% of the global burden. Meanwhile, half of our TB patients are also living with HIV. This means that any strategy that does not address both the TB and HIV epidemics will not succeed. This year, the theme in the fight to end tuberculosis is yes, you and I can end TB. This message serves as a clarion call for individuals, families, and communities to play a role in the fight against TB. Recent progress in TB vaccine development offers a glimmer of hope in our journey towards TB eradication. TB is curable if patients stay the course till the end, eat healthy food, and live a healthy lifestyle. Then we can indeed end TB. We are now joined by Professor Kogie Naidoo. He's a Deputy Director and the head of the Treatment Research Program Center of the AIDS Program Research in South Africa, CAPRISA. Professor Naidoo is also a clinical member of National Drug Resistant TB Clinical Advisory Committee, National Department of Health, South Africa, an honorary associate professor, College of Health Sciences, University of KwaZulu-Natal, South Africa. Professor Naidu is also on the WHO's TB HIV Technical Working Group and a board member of the prestigious South African HIV Clinicians Society. She was honored with the coveted 2013 Union Scientific Prize for her contribution to advancing TB science worldwide. A great honor to have you amongst us, Professor Naidu. Welcome.
Thank you very much. Thank you.
Thank you so much, Ashok Bhai. It really means a lot, and all our energy and best of wishes for you are already on healing and recovery way. We really hope to listen more of your radio voice, as we say, which went on the airways for so many decades. So, Kogie, welcome again. It's really important for us to have you. I know you must be very busy. So, Kogie, can we have your insights on the entry gate to TB care pathway, which is diagnostics? I think we are missing a lot of TB cases. I come from India. I'm in India right now in Delhi. We are missing cases even among those who take a TB test because of microscopy, for example, which underperforms in diagnosing. Despite a WHO call to replace microscopy with molecular testing, upfront molecular testing, the rule in India, it is about 21% as per the India TB report 2024, which we read about in the news about a month ago. So 21% in 2023 molecular testing is really very low. And of course, we are struggling to reach the unreached. In South Africa also, there are about 70,000-80,000 people who are unreached. Molecular testing, I think, is 74% as per the Global TB Report 2023. So please, your insights on why it is important to find all TB, we are to end TB in South Africa, in African continent, or globally. Over to you.
Okay. Thank you very much for your question, Bobby. Finding TB is central to ending TB. Finding TB is central to reducing the transmission of TB, because when you find TB, you enter people into the diagnostic pathway, you get them into the therapeutic pathway, or in the TB prevention pathway. So if you can exclude TB reliably, you can offer TB preventive therapy. But if you identify TB, you then put patients into a therapeutic pathway towards cure or treatment completion. The goal of this obviously is to save lives of the individual affected by TB, but more importantly, the public health goal is to reduce onward transmission of TB from somebody with the infection to those around them, close household contacts, close members in the community, and close members with which they interact with, because person-to-person transmission through the air is how TB is transmitted. The last decade has seen enormous strides in improved diagnosis of TB. In the past, we've had to wait 3 to 7 days in which to get a smear result, because smear microscopy has been with us for as long as the microscope has been with us. So we first identified TB. We know that Robert Koch identified it in 1882, and more than 140 years ago, right? So it's a long time. We were using the microscope to find TB. But since 2010, the world has moved towards a molecular-based test. In fact, almost every country in the world has adopted molecular-based diagnostics for TB. But it's really about scaling it up and making it accessible to every single person that desires a TB test. So we've had improvements on TB diagnosis using a molecular test by up to 30 to 40%. So the same sputum from somebody that is subject to smear microscopy that now gets subject to a molecular test increases the likelihood of us finding this TB and initiating a person on TB treatment. This is especially important for individuals that when they cough up, do not cough up enough organisms that we are able to identify with microscopy. But with the nucleic acid amplification testing, the detection rate, even in what we call porcibacillary TB, fewer bugs, is that much higher. The technology has been improving in that the detection rate is better. And not only are we just identifying TB, we are identifying resistance, TB drug resistance, with a single test. And that is so important because we know that TB drug resistance requires an alternate approach for drug choices, an alternate approach for duration of therapy, an alternative approach for monitoring treatment response. People with drug-resistant TB face an even higher proportion for mortality, for death. So having molecular tests is important. Having molecular tests that are sitting in a lab far away from people also is not helpful. You need to actually have a test at the bedside to be truly transformative. And we are not there yet, Bobby. We still are far from that. The tests that we have capability of being point of care. However, given that the expense of rolling it out into decentralized primary healthcare clinics, decentralized laboratories, it's still an aspirational goal to take whatever technology we have to the bedside. So we have a replacement of smear microscopy. We have replacement even of culture, where we now can use this expert XDR that will help identify TB drug resistance. There are newer technologies that are emerging that's going to help us identify treatment response monitoring. Is people getting better? Are the sputums clearing? Do we need to go back to the old systems of culture? And so we are moving in that direction. So certainly, the diagnostics are improving. Currently, the issue is not just a diagnostic issue. The issue is people and health facilities not identifying TB. TB, we know, classically presents with cough, fever, night sweats, weight loss. 4 symptoms that the community is well aware of. The problem is when you have respiratory infections like we see in colder seasons, people get a common cold. The COVID-19 has confused people because cough is a very dominant feature. And so they think, perhaps it's the flu, perhaps it's influenza, it's something else. And so they delay seeking care and they try all the alternate remedies. And I know in India, people would rather seek healthcare that's alternative rather than going to allopathic services to seek a diagnosis and seek a treatment linked to the diagnosis. So the issue then is people self-identifying that perhaps I need to go and have a diagnostic test. It's those family members of a diagnosed TB patient that don't yet know that if there's a family member diagnosed with TB, the whole family needs to be screened. If there's a colleague at work that's been diagnosed with TB, everyone working with that colleague in close proximity should go and get a sputum test for TB. And then there are those that do not have the classic symptoms of cough, fever, night sweats, and weight loss, where they may present only with weight loss, only with loss of appetite. They don't have the classic respiratory symptoms. And we've seen that in our own country, where 67% of our patients in a recent national prevalence survey did not have features of TB. But when their sputum was subjected to culture and diagnostic testing, TB was identified. So the TB that's occurring in what we call asymptomatic individuals are also contributing to this failure to diagnose. We think that the gap between diagnosis a bit between the burden of TB in the community and those that seek a molecular test or seek a test for diagnosis is about 30 to 40% in some settings. So that means there's a lot of TB in the community that is not yet diagnosed. And so it is important for us to close that diagnostic gap. I'll stop there and take further clarifying questions from you, Bobby.
Yeah, thanks a lot, Koji. This is was really so important and really an eye opener also. Imagine 67%, if I heard correctly, were asymptomatic in South Africa. In India also, Koji, as you probably already must be knowing, as per the Indian government's National TB Prevalence Survey 2021, 42.6 or 7% were asymptomatic. But out of bacteriologically confirmed cases, more than two-thirds were asymptomatic, which is like really large. In Nepal, I think 70% were asymptomatic as per Nepal government's TB prevalence survey. So this will come. We should come back to this discussion about asymptomatic before, because I have some more clarifying questions. Also because Professor Guy Marks, who is the president of the union, and he's been a very long time advocate of trying to share the example of richer nations like Australia, Japan, 50 years ago, 1970s, when they screened everyone with whatever tools they had, and subjected everyone for the TB test so that they can find all the cases and try to bring them to TB care. And they did this year after year after year till the TB rates 50, 60 years ago went to below elimination levels. And even currently, there are countries where TB is already at below the elimination levels, and Australia is another example. So, perhaps so in Vietnam, Professor Guy Marks did a study in a small part called Kamau. I should not say Professor Guy Marks did the study. He was involved, but of course, Vietnamese researchers were the real heroes and heroines who did that very important study. They screened everyone with the molecular testing. They did not had the ultra portable X-rays 10 years ago. So 10 years ago, 2014, 15, they screened everyone with molecular test, and year after year. And in 4 years, there was a decline of 74% in TB rates. Even in children, the TB rates fell by 50%, half. This is a lot. So I will come back to this because I need your insights on if should we be screening everyone. But before we go towards that, I'd like to talk to you about diagnostic delays. It is really important for people to get tested on molecular test, but diagnostic delays are huge. In some interviews we are doing with homeless people and migrant workers in India, who have completed treatment now. So the diagnostic delay was more than a year. In one of the cases was about 3 months in another case. And Dr. Susmita Chatterjee's study, which has come out very recently, I think it is in PLOS Public Health also. It got published last week, I think. The diagnostic delay was about, I think, 12 weeks. This is a lot of diagnostic delay if we are to stop the spread of infection. So can you please share some insights why it is important to really find early? We have to find early if we have to end TB, as you have already emphasized so much on why it is important to find all. But let us also hear your insights on why it is so critically important to find early and eliminate diagnostic delays. Over to you.
So TB is progressive if untreated. Patients may present with symptoms, and if ignored, the TB will spread within the lung itself, forming cavitatory disease. That means they form holes in the lung that communicate with the outside through the airways, enhancing the risk of transmission. The longer the time a person spends not being diagnosed, then the delay there is in getting appropriate treatment, the greater the chance of transmission, the greater the chance of extensive disease in the lung, and the greater the possibility of that TB organism spreading via the bloodstream to other parts of the body, what we call disseminated TB. and presenting with TB abdomen, TB brain, TB meningitis, and so on. And it's a more severe form of treatment with a very high mortality risk and requires far longer, more sophisticated diagnostics, far longer treatment. So there's the risk to the individual, there's the risk to the public. Early diagnosis is important to help mitigate all of those challenges. The delays comes from people not recognizing that they have TB, or they present to the health facility, they don't get offered a test. Sometimes they are offered a test, but the healthcare worker does not educate the patient sufficiently on how to produce a proper sputum sample and not give saliva. We can't diagnose TB with saliva. We can diagnose TB with a proper sputum sample that's coming from within the lung or the lower respiratory tract. Teaching patients how to give a proper sample is important for us to enhance our ability to catch the TB. Thereafter, the healthcare worker or the patient themselves will not seal the sputum jar adequately, so there's leakage of sputum. The leakage of sputum means that there's insufficient volume of sputum to run a diagnostic test when that sample gets to the laboratory. And that then contributes to delays from the time the patient enters the health service, offers a sputum test, and then goes in and gets a molecular diagnosis. Then with COVID-19, we had such sophisticated mechanisms of linking people to a result. We used SMS. There was, there was this huge groundswell of education telling people you must know your status so you prevent transmission to other people. We do not have such a thing with TB. So a test result may be available, but if a patient, for whatever reason, financial, social, health reasons, cannot get to a health facility, they're not accessing their result. They're not accessing linkage treatment. There are basically delays in getting them onto appropriate treatment as a result of that. So we have issues with poor quality sputum. We have issues with delayed turnaround time of results for whatever reasons, either it's a poor sample or poor access to services. And then the healthcare worker not acting timeously. And the nature of it is that patients will shop. They'll go to the health facility, they'll go to the pharmacy to get a quick fix. They may try an alternate health healer, just say, some faith healer or a traditional health practitioner to get something to help them feel better. So they delay coming back for appointments to be linked to their result to start on treatment, thinking that they may get help in other forms of treatment. It's a part of our education of the public is that TB is caused by an identifiable organism. There is a set way in which we treat it. People need to start and end therapy in order to eradicate it from the body. So all of this is part of it's similar to the education we got from COVID-19, mask, stay at home, try non-pharmaceutical interventions, prevent, limit onward transmission, and so on. So there was good health education around that, but we're not doing the same for tuberculosis.
Yeah, thanks a lot. Very important again. I think we need to not forget the lessons which we have learned from COVID-19 pandemic and to see.
So it's excellent. It's excellent to hear, Bobby, but perhaps that needs to be linked with a strategy of directing the testing to those that will most likely benefit to improve your yield of positivity, the positive yield, the targeted testing. So it's wonderful to have widespread access to molecular testing. But how do we ensure that we get the best results from it? And part of this is having a very good insight as to who is being diagnosed with TB. Are these children, vulnerable children under 5, a household member of an index TB patient? Is it a family member? Is it people living with HIV? Is it diabetic patients or those on some sort of immunosuppressive therapy? Is it your homeless population, or your malnourished population? How do you direct the test and perhaps not wait for symptoms like we've discussed and touched on briefly, that we offer targeted universal testing irrespective of symptoms, because that's how we're going to break the back of this epidemic, is to try and catch as many people as we can, even before they show symptoms, so that we can curb transmission, onward transmission.
Bobby,
Yes, Ashok bhai, please. Go ahead.
what I'd like to know, is the government doing enough to combat TB?
So if that question is directed to me, Ashok, I don't think governments throughout the world are doing sufficient to combat TB. I think that, health budgets are cut up in so many different fragments that we do not have sufficient resources for TB, and we don't have sufficient dedicated effort in preventing TB and in diagnosing TB. Because once you know a person doesn't have TB, that's a remarkable opportunity to put them onto TB preventive therapy to keep them protected, because prevention should be our number one goal.
Totally agree with
While
you.
we're waiting for a vaccine, that we put people onto preventive
Sure.
therapy, and to have policies where we do more for targeted universal testing. In a country like South Africa, where non-pregnancy related infections is the number one cause of death in pregnant women, where we know that that is actually tuberculosis. We took a long time before we made universal testing, TB testing, available to pregnant women. The antenatal guidelines in many low and middle income countries was we screen for a host of infections when a pregnant woman comes for services, but we didn't include TB in that package of screening interventions. And that was low hanging fruit, because not only do you protect the mother, you also protect a newborn infant. So there are strategies that we can deploy and investments that we can make. Governments throughout the world have not done enough to aid and accelerate investments in, for example, TB vaccines. And we need TB vaccines. We need an enabling environment to trial out TB vaccines to get us closer to an effective vaccine. So it may not necessarily be in the form of money, but to create an enabling environment in which to get some of this work done.
Yes, I totally agree with. Okay, moving on. Is there enough public information for people to understand the importance of the disease?
I'm not sure what exists in India, but Ashok, TB is our number one cause of death here in South Africa. But if you
Yes, I'm listening
travel,
to South Africa.
and if you travel anywhere in the cities, the major cities in our country, our beautiful country, or you travel from our airport towards the cities, there is no billboards. There is no public education on an ongoing basis around tuberculosis. We hear a lot about TB in the run up to World TB Day that we honor and identify with in March each year, but then we silent for the other 11 months of the year. We do not do enough to enhance public education, even within health facilities, within HIV clinics, where we know our people living with HIV are extremely vulnerable to TB. There is, in the short answer, Ashok, is that there is insufficient education around what are the evidence, the signs and symptoms of TB, and what an individual can do to access a test, access treatment, just to empower people with education so that they can actually identify with the problem and know what to do if they think that they suspect that they have tuberculosis.
Thank you for that important information.
Yeah, thank you, Ashok
Over
bhai.
to you, Bobby.
Yeah, thanks. Tell us more about, you're talking about screening everyone. So in India, we are deploying ultra portable X-rays. So in states like Uttar Pradesh, for example, which is really difficult in terms of health, from health and disease, we deploy these to screen everyone. And in the villages, and molecular test TrueNat went to the block level, because it can be taken, deployed at that kind of a level because of being battery operated, lab independent. So the yield was historic. It was 100,000 more new cases they found last year, just in one state. 100,000 new cases. Imagine, and that too from, as you rightly said, where are we looking? So among homeless, among migrant people, among populations which were earlier getting missed. So what are your insights on how can we find screen everyone in settings like South Africa, for example, or other African?
Yeah. So, Bobby, South Africa is also evaluating the chest radiograph for TB screening. It can be used as mass screening tool out in the community. And the WHO has approved it as a potential screening tool. But I think what we need to understand is that TB is a great mimicker. So TB in the lung on X-ray looks very much like other conditions that you get. The most important thing of a chest radiograph screening is if it is clear. It is a rule-out test. That if somebody with a clear X-ray, you can comfortably say to them, we can't see evidence of TB, we don't need to do anything further for you. But if we see a spot on the X-ray, then we say, you need to have a test, a TB laboratory-based test so that we can investigate further. So I think it's a very useful tool for mass screening. Symptom screening is also a very useful tool. Surveillance, national surveillance, regular rotating national surveillance helps us identify hotspots, which communities, which geographic locations are facing a disproportionately higher burden of TB compared to others. And let's then target those areas to do mass screening so we get better yield. Other countries adopt a strategy, pre-employment screening for TB, or before some important anniversary event that you would go for a TB screen, annual screening for TB. In large populations such as in India, that may not be viable. So we have to come up with innovative strategies in which we can deliver mass screening. The simplest thing is education. Everyone knows when they need to go for a TB test. Secondly is high-risk groups, diabetics, people living with HIV. These individuals should have annual or on-demand TB testing available to them. And I think the key for on-demand testing, especially with cheap, readily accessible molecular tests, is something we need to start driving. That people should self-select and say, I think I'm at risk for TB, I'm a smoker, or I live in a shelter. I'm going to get a free TB test with a friendly healthcare worker who will help me to get a proper sputum sample and advance. The march forward for more readily accessible and ready-to-read diagnostic tests like an oral swab is actually greatly going to help us to do mass community testing. If we can just swab a tongue swab or an oral swab, and that's going to flag positive, as a screening test for TB, will be an enormous game changer. That means anybody can have a TB test and then based on that, present to a healthcare facility. So I think that in tandem with strategies for mass screening, advances in diagnostics will actually get us closer to the goal of universal testing for TB.
Yeah, thank you so much. Thanks a lot, and all the best for the South Africa National TB Conference. The whole world watches that conference. We're really looking forward to that. It's in Durban, right?
Thank you very much. Yes,
yeah.
It's
great.
In Durban. It's actually in a few weeks' time, so we're really looking forward to it.
We too. We have been watching virtually, but great, Kogie. Thanks a lot for joining us. And let us hope what you have just said, new tools, deploying what we know already works, even better, focusing on populations which are more at risk. Let us hope we do all what we can. And of course, while we are advancing R&D for even better tools. So thanks a lot for joining us. Really means a lot, Ashok, that you joined us from Durban. So all the best in terms of health and everything to both of you. Thank you. Thank you. Take care.
Thank you, Bobby. Thank you, Ashok.
Thank you,
all
Bobby.
the best to you both. Thank you for the lovely
Thank
work.
you, Prof.
Thank you.